Hi, everybody. It's 1:15, so we'll go ahead and get started. Thank you all so much for joining us. If you didn't hear my announcement the first time, there are biscuits in the back. Please help yourself. There's also some candy and green cookies as well. So please help yourself. There's also a sign-in sheet, so it'd be great to have your contact information if you haven't already signed in. So welcome everyone. This is Clinical Information Provision in an Era of Hospital Mergers and Acquisitions. This is the 24th Health Sciences Lively discussion. So thank you all for coming. I recognize a few folks. I see a lot of new faces, so it's great to have you here this afternoon. I am Sarah McClung. I'm the head of collection development at the University of California, San Francisco, and I'm very happy to be your moderator for this session. I want to start off by acknowledging my co-organizers. There were a number of us, there we go. There were a number of us that came together to make this session happen. The first I want to acknowledge is Montie Dobbins here in the front. She is our timekeeper today. She's from Louisiana State University Health Shreveport. She was the one who brought the biscuits as well, so thank you very much, Montie. I also want to acknowledge Kim Steinle. She works at Health Affairs. Unfortunately, she wasn't able to join us today, but she was instrumental in bringing this group together. So huge shout out to Kim. And then lastly, of course, I want to thank Ramune Kubilius from Northwestern. She is the reason this is the 24th Health Sciences Lively discussion. She has shepherded this session for over 2 decades. So thank you very, very much, Ramune, for making this happen for so long and so successfully. So with that, I want to welcome Ramune to come up. She wants to go over the developments handout that she creates every year and give us some updates on some new resources. So Ramune, please join us.
Thank you all for coming. Every year, right after one Charleston conference, I start keeping lists of things that are happening in our landscape. So I follow what the National Library of Medicine is doing. I haven't heard that they have a new director yet, but I think they're finalizing the search. And of course, all the resource information tools that NLM develops, but also what our publishing partners. So a show of hands, how many here are here from the publishing community or vendor community? So that there are some of you. Thank you and welcome. Thank you for coming. We watch what you do. We partner with you when you can. And if there are any changes going on, please inform us, because one of the items on my list is one of our publishers, vendors, made some major changes this past year that surprised some folks. This handout that I developed, the QR code is there, is deposited in the institutional repository at Northwestern University's Galter Health Sciences Library. And after this conference, I'll be depositing the slide deck from our speakers as an associated deposit. So if you want to review anything, please feel free to do so. So what I do there, I look at anniversaries, everything from AAAS, the grand old publication at 175 years, all the way down to the 5-year anniversaries, annual reviews, doing it Subscribe to Open, being the first to do it, and medRxiv and some of the others, and all the ones in between. So it's kind of fun watching how things develop, merge, change. So it's kind of a journey for me, and as I walked through the vendor showcase, I realized I certainly missed a few things, so I don't pretend to be comprehensive, but it's always fun, or sometimes a rude awakening to find a name change for a database that you didn't know changed names because the last invoice still had the old name on it. That happened with natural medicines becoming NatMed Pro or with Rittenhouse making some business decisions, some changes. And then the role of AI, we've been hearing about that all throughout the conference. Some of the partnerships are great, collaboratives, those are things to follow. And then I even have the coming in 2026, some publishers and groups are already announcing things that are coming in 2025 and 2026. We do note the retirements, Dan Duty retiring, but duty core titles is safe in the hands of Tim Budson, a librarian who's worked at duty for quite a while, so that was something. And we also know the passing of Fred Roper, many of us followed his introduction to reference sources in the health sciences. So those are just, and Medical Heritage Library closing shop. So for those who follow the repository scene. And if anyone's interested in that, there will be a medical repository virtual symposium coming up on November 21st. So if anyone's interested in that, it's called MIRL, M-I-R-L. So please join us if you're interested in that. It's a free one. So I leave it now to the topic at hand. To my recollection, this is about the third time we're really focusing in on clinical. So I hope we have a lively discussion and we have some experts to tell us more about it from where they're sitting. Thank you.
Thank you so much, Ramune. Now I'm going to introduce our panelist for everybody. So first up, we've got Doug Williams. He is an associate professor in the College of Health Professions at the Medical University of South Carolina, just down the street. So thank you so much for joining us today, Doug. Next, we've got Dan Begard. He is the university librarian at the University of North Texas Health Sciences Center at Fort Worth. And he is also the director of NNLM Region 3. And lastly, but of course not least, is Renee Barker. She is the Associate Vice Chancellor of the Health Sciences Library System at the University of Pittsburgh. So welcome, panelists. Thank you so much for joining us today. As you can tell, our session is primarily focused on academic institutions that have affiliations and partnerships with medical centers. That being said, we hope that the information shared today is applicable to all sorts of folks who have contacts with hospitals. And this is the part where we're going to ask you to move just a little bit. I know it's after lunch. We're really curious about the makeup of our audience. Ramune already asked for the vendors, so I'd love to see a show of hands for academic librarians if you consider yourself academic. Nice little stretch, perfect. Are there any hospital librarians? Excellent, thank you so much. That's a great turnout. We weren't sure how many hospital librarians were going to join us, so it's fantastic to see. Thank you all so much. The panelists will have about 10 minutes or so. They have some prepared remarks. They all have a lot of experience with hospital mergers and acquisitions. Dunk has experience more on the hospital finance side, some words about hospital administration, and then of course Dan and Renee will talk about more of the librarian effects of the mergers. So with that, I will let Dunk take it away. Thank you all so much.
Wonderful, thank you. Can you hear me? Perfect, okay. Look at my word bubble. So Doug Williams, happy to be here with everybody. I'm not a librarian, so I have a background in healthcare administration, and I teach and research in the area of healthcare finance, but in particular, maybe what relates to today is around mergers and consolidations. I work in this space, long-term care space, but also particularly in the hospital health system space. So provide a little bit of background about what's going on potentially in the industry, and then hopefully related to a lot of work that most people are in, from publishers, hospital setting, academic medical setting. What I have here, good, this is my slide. I intentionally don't wear my glasses anymore when I present because it very much makes a blurry audience out there for me. So can't even see my own slide for me, but this is a slide I'll teach in a finance class next week when I talk about mergers and consolidations. And it's a slide that I've evolved but worked from for several years now. On it, nowhere do librarians fit. Talk about board of directors and executives. Those are the folks that there's often a direct connection to what's happening with mergers and consolidations, and administrators and vendors and who's being acquired. And I spend a lot of time talking about the team members and librarians. Everyone in this room fits within that, or publishers fit within the contract agencies, and the patients. So trying to keep the patients at the center, which is where it needs to be. So I do think librarians fit into team members that I've been talking about the subject for a decade. But I, until the past 6 months, have never directly talked about the impact or associations of hospital mergers, healthcare affiliations, and librarians. So it's been an interesting run. A couple things we'll talk through with some data. Now, those are parties that I think could be potentially impacted and are. So from the healthcare landscape. What's going on? Let's talk some of the historic. So there are roughly 4,500 short-term general care, acute care hospitals. So what we typically think of as non-specialty hospitals in the U.S. 4,500 hospitals roughly, okay? So we've seen in the past 100 years, there's been a proliferation of growth in the number of hospitals and beds. And then particularly the past 30 years, we've had more a shift from outpatient care where reimbursement shifts to more favorable profit margins around outpatient care. And so there's been a small number with some of the hospitals. But there's also been a variety of merger waves in the past 100 years. So we are in a wave now. Since roughly 2010, of the 4,500 hospitals, each year for the early 2010s, there were over 100, if you look at the time too, so make sure I'm not going over, because I like talking about the topic, so I could go on and on. So at over 100, and last year there was 65 of them. So that's still a high number. Hospitals, profit-wise, the industry on average has some stability there. That can be argued depending on the group, but when I look at the numbers and I crunch it, 4 to 5%, that's a stable market for 4,500 hospitals. Now the difference gets into the heterogeneity within that market of 4,500 hospitals. In particular, the US, we have what is a good problem, but a geography problem. We have a lot of land mass to provide access to acute care, which means there are roughly half of those 4,500 hospitals are rural hospitals. And so from a rural standpoint, there have been a high number of rural closures. Since 2005, there's been nearly 200 of those, as tracked by the UNC Chefs, North Carolina Rural Health Research Program. They're the premier group tracking that. But even in urban settings, there are closures and bankruptcies, and in particular and relevant, the wave we're in. So we've seen more mergers, and the numbers are, in 2016, there were about 700 hospital systems nationally. In 2022, there were 404, so a 7% year-over-year run rate in the decreasing size of health systems. Now we know that most of us are not feeling the impact of less hospitals out there, but what we're obviously seeing, what does that mean? That's larger consolidation. The deals get bigger and bigger, pretty much on a run rate every year since I've been doing this for 10 years, looking at it from a research standpoint. So there's bigger deals, there's more consolidation, even amongst those already consolidated. So as waves go, likely there will at some point be divestitures of those. We haven't seen as much of that now, but there's potential for that. There's also potential that it could be going into a continued cycle of larger and larger consolidation. And we'll touch a little bit on how that might look from a numbers standpoint. So we have bigger deals, more deals going on. Still with 65 last year, we've had the COVID impact, and so there's still a relatively high number of deals considering how many hospitals are out there. The types of deals last year, more bankruptcy, foreclosure, style, distressed sales or acquisitions. What does that mean to me? That means there's more financially distressed hospitals being acquired or health systems last year, a very high proportion relative to those in the past, okay? So that relates to probably a theory of value purchasing from an acquisition standpoint when you look at theory around why health systems may be doing that. If there's value and we need to make a profit, revenue's money to bring in, expenses out. We have two ways to increase profit. Increase revenue, which is oftentimes largely fixed beyond growth. And so there's decreasing expenses, okay? And so anybody out here will take a wager and say, what do you think is the largest healthcare expense for every academic medical center there is in the nation like this? What do you think it is?
Personnel.
Personnel, thank you. Labor, roughly half, 40 to 60% of your costs, on average, it's about 45, 48%. Personnel costs. So that may be an opportunity if you're looking at expenses to talk about. And I'm not here, I don't expect the library is where things are getting cut with that, but I know that's a question that has come up in our discussions of what does that look like? So I'm really appreciative of some of the numbers that I received last night from MUSC's library. Shannon Jones, she's here, thank you so much. Do what?
I think she just came in.
Wonderful. Okay, well, if you're here, thank you very much, but I received these numbers last night only because I made the request very close to last night, very, very shortly before that. So that's on me, is why I have the numbers. But I was typing some of this out right before I walked over here and used a printer. And that's what, from a research standpoint, and I research in this space, I'm a very active library user, hopefully not aggressive, but a frequent clicker, frequent user. So I think my name probably came up from the utilization list. So thank you for these numbers. Now, I'll put some of these together. Library expenses, and let's take MUSC, an academic medical center, and if these are relative to other centers, but in 2023, library expenses, 12 million total, 4 million roughly for salaries and roughly 46 employees. But I don't want to get lost in that. I want to get to where I converted it into percentages. So I pulled MUSC's financials from last year and I converted it. And so here's what I think of as what's the benefit and what's the cost. And that's where I'm getting to what do I want to leave you with. So for MUSC in 2023, and there were some reinvestment capital expenditures for one of the libraries, but overall, MUSC's library costs less than 1% of total operating expenses. And the labor was, by what I roughly calculated quickly, a third of a percentage, so 0.31%. Very small numbers when you convert it. Because I can say MUSC is 4 million labor and 12 million, it doesn't matter. It's not relative in talking in those terms because everybody's a different hospital. So I like things in percentages, proportions, and ratios. Now, then I went and found how much research funding MUSC does because I suspect this group, I know from my standpoint, it's necessary to have all these electronic licenses and accesses. And my textbooks, they're all electronic for my students too. So thank you. Thank you for everybody making these possible. MUSC $300 million in research funding last year. So converted those numbers into that, and I'm losing them here. So they're both very low. So labor was 1.53%. So you're spending $4 million on labor, library labor, and you're generating $300 million in revenue. So when you're having the conversations, what would I do if I'm in the library standpoint? I like converting things to numbers because everybody can speak numbers whether you like them or not. And from my standpoint, when you're making mergers, people aren't directly talking about library, but they're not directly talking about any of these groups. But direct revenue generating cost centers like your cancer and transplant, those have direct numbers. Library may not have direct numbers, and I'm sure there's other things like these per clicks, the 947,000 from MUSC that I was probably 2,000 of. So those, that's great, but I'm tying it to revenue. And of research revenue of 300 million, we spent 4 million last year on labor costs, okay? So I think that's relative to think about as there are particularly things around labor and attrition and things like that. So how are you tying cost to value, defining those and making it relevant? But we have 1 minute, I wanna make sure I'm good. 1 minute, so. In 1 minute, and I'll finish up with what my thoughts are. So managing relationships, promotion, I think education is done often best by keeping things simple and by repetition. Repetition is teaching, and then promotion. As a researcher myself, I'm terrible at self-promotion. I don't know if the librarian crowd is terrible at self-promotion as well, but I can relate that self-promotion is a difficult thing, but we have to have that. And then also being aware of things, not waiting until the email comes out in the system, because that's going to be the last one after the newspaper. But before the newspaper notice, know what's going on. Oftentimes vendors know that things may be going on around mergers because they're getting quotes to see, is this a deal in the non-disclosure period, things like that. So, and then just, that's it. I think manage relationships. I'll close and I'll pass it over to Dan. Excited to hear from them.
Thank you very much. I'm, again, Dan Burgard from the University of North Texas Health Science Center in NNL Region 3. I'm going to bring things into the library, and you'll hear also some library specifics from Renee. Is my slide showing? Oh! I'm not coordinated enough for this. Real quick, well, I'm going to tell you a bunch of stuff you already know on this slide. What are we doing in a hospital or an academic library? We're bringing together people, resources, services, and space in order to meet the needs of our user groups. Specifically for a hospital library, whoever's managing that, and they're supporting patient care, management, business decisions, research, and education enterprise in the hospital, as long as most likely patient and family information needs. We impact all of those things in a very positive way. We need to be vocal about that impact, as Dunk already said. Let me move on to my next slide very quickly. What are the specific impacts of mergers and acquisitions on a hospital library or an academic health science center library that's serving the clinical needs of a hospital user group? I want to drop down to the bottom couple bullet points on there, which I call lenses. This is just us acknowledging that what we're talking about can vary wildly depending on whether you're being acquired, your institution's doing the acquiring, who's doing the merging. There's also a private versus public institution aspect to all of this. Things can work radically differently. I am from a straight up publicly funded health science center in Texas. We are not going to merge with anybody. We're not going to be acquired by anybody. Different world in the private sector. There is also, I'm going to talk about this a lot, an urban and rural distinction. I live in Texas. There's 254 counties in Texas. Over 80 of those counties don't have a hospital. Over 50 counties have no physician. So this is a really different topic depending on where you're at. I suspect much of what we're talking about right now impacts urban or at least reasonably mid-sized populated areas. Go back up to the top. Where did I gather? I have specific examples to talk about on those bullet points. You know, probably if you're the fine group who raised your hand, you work in a hospital library or an academic library. Licensing user groups and access is a constant part of your life. It can be very confusing. That's what I got when I was doing my information gathering for this session. I talked to a handful of librarians who've been through or are actively in the middle of being merged or acquiring, maybe their institutions acquiring other ones. Oh gosh, the stories on licensing user groups and access. This would be, I'm going to speak generically about where my examples came from. Most of the people I talked to didn't want their institution identified. I can say that my examples come from hospital systems that are in large cities on both coasts. And then the one nice group that is fine with being identified is out of Texas. They were the most satisfied out of their merger. Licensing user groups and access. So an example, you get a phone call. Hey, this is Montie Dobbins in hospital administration. I run the education department. Guess what? We just bought, this literally happened. We bought a hospital on the other side of town, and you're now in charge of that library. They have 2 staff members. They belong to you now, and you have a whole new user group. That was all the information that was given, and then you go figure that out. So this is clearly a huge impact of a merger or an acquisition. Information technology, different system. Big merger happened. The merged organization upgraded its, oh no, I'm drawing a blank. Its Epic electronic health record system got some new capabilities, and the library was mandated to start offering all of its electronic resources through Epic. Guess what? When you do that, Epic throws off a whole different IP number. All of their licenses had to be negotiated. And to work with the IT operation in a hospital, we know of necessity, but they are very tense and they are very strict on how things can be done. I have 5 minutes left. Service expectations and philosophy. Back to my original example. Hi, ring, Montie Dobbins. You got a new hospital with 2 employees. Well, guess what? Those employees both worked there 20 or 30 years. They have grown up in an entirely different hospital with different service values, different annual evaluation processes. So now all that has to be worked out as well. I don't have a lot to say about funding. Human resources, I've already touched on that a little bit. You could lose employees, you could gain new employees, and you have to react to that pretty much on the spot. I mentioned in this audience, Rosanna Ratliff, who's sitting to my right, your left, is part of a very large merger in Texas between the Baylor Health System and the Scott White Health System. They now have over 50 hospitals and over 900 patient care locations across Texas. They maintain 2 robust libraries that are somehow now related and not necessarily merged into one. They were the happiest of all the people that I talked to. Thank you. Perhaps that's because they were very similar to begin with, academic oriented, but also serving pretty big patient care operation. Let me move on just really quickly to my last slide. what is your responsibility in all this situation? I think Doug has already touched on several of these things, being proactive and not reactive. My general mantra before I ever even contemplate talking on this topic, know your people, know your business. I would usually say that in the library. When I say business, my normal spiel, that means you know the library operation. Well, you also need to know a lot of things Doug was talking about. You need to know the healthcare and hospital administration world in order to do the best job in representing your library's value. And the second bullet point, be vocal. That's probably the biggest thing of all, just being vocal. Get out there reminding your hospital administration how you improve patient care, you reduce errors, you reduce risk, and you improve patient satisfaction. I don't need to talk about the third one, which is using all available admin structures and networks. Get on hospital committees, use all your local, state, national consortia that are available to you. And of course, the NNLM regions are always available to work with you on specific issues that come up. They can provide funding and training for you. My library is responsible for the hospital library operation, the county hospital that's in Fort Worth, Texas. That's a tax-supported level 1 trauma care center, safety net hospital in a county with 2.1 million people. My one mandate to my 4 staff members over there is simply spend more time outside the library than in it. They're always out and about working with clinicians in hospital departments, serving on committees, and we've been very successful over there in managing our services and resources. With that, I'm going to pass it to Renee. I'll be happy to hear your questions when we're all done. Thanks.
Thank you, Dan. Thank you, Doug. Can you all hear me okay?
Mm-hmm.
Again, my name's Renee Barter with the University of Pittsburgh Health Sciences Library System. The University of Pittsburgh is a state-related public research institution, and our library serves the education and research missions of the 6 schools of health sciences at the University of Pittsburgh. We also manage all the electronic resources for our large affiliated health system, as well as provide research and instruction services for the graduate medical education programs within the health system. We've been through both acquisitions and mergers, and I've been there for a little over 20 years, in my current role for about 3 years. But we have come up with a consistent model that I'm going to talk a little bit about with you all today. So in our model, we license the same suite of electronic resources for the entire clinical enterprise. We manage a digital clinical library catalog for the entire health system that's specific to get them to clinical resources, because they're not PIT employees, they're clinical staff. About 40% of the faculty at PIT do also have physician appointments within the health system. We also integrate the electronic health, the digital library catalog, and applicable resources within the electronic health record and other decision support tools within the health system. We troubleshoot access issues, provide, as I said, research and instruction services only for the graduate medical education programs within the health system. So as Dan noted, know your business, that's our business. That's our consistent model that we have made known to the health system, that we communicate to the health system when we're talking about our value in coming into the health system to help them with their resources. That's our consistent model. We do have a collaborative model with existing hospital librarians and libraries that are in the system. It's been the practice of the health system to maintain the hospital's libraries and librarians in any of their mergers and acquisitions. These librarians remain employees of the health system, so they don't report to us in the academic library. However, we collaborate with them consistently. We actually have a program manager position that's fully supported by the health system that organizes monthly meetings with the librarians. Our liaison from the academic side that does services to the residents and fellows meets regularly with the hospital librarians, because the residents and fellows are also going to the hospital librarians. So we do have a very much collaborative model. We help them, educate them on the resources. They, in turn, are essential to getting the resources into the hands of the clinical staff. And so I think and advocate for, whenever there is a merger coming up, if there's an existing hospital librarian on staff, that they do maintain that position, because that's the best way it's going to be successful. I'd like to take a few minutes to discuss some factors we consider when, and the valuable partners that we work with. Many of these have been mentioned already. But again, I think the biggest thing to keep in mind is to really, as an academic library, define your role. Because provision of clinical resources is a lot more than just licensing the resources. It's defining all those things that I mentioned before in our model. Are you going to be the one responsible for a digital catalog? Are you going to be the one that's responsible for managing those vendor relations, for assessing the resources? Are they being used? Are they getting in the hands of the right folks at the clinical areas? And also, are they meeting the needs? So all those things to take into consideration when you as an academic library are negotiating these things and what it's going to look like as the merger takes place. And to make that known up front, there are obviously, as you know, staff and resource costs involved with that. So these are the discussions that I recommend that happen in the beginning as you're going through this, or if it's going to continue, so you can make sure you have the support you need. I'd also like to just highlight some of the internal partners that are also key players when mergers are happening. Some have already been mentioned. The IT department obviously is key in the hospital. If librarians are there, the hospital librarians are key. Supply chain management, they help us figure out, especially when there's not a hospital librarian, they help us figure out where the money has been being spent within the health system, what resources they might already be subscribing to, so we can be in touch with the vendors to talk about merging those licenses. Also, we uncover that resources maybe are being licensed by departments or units within the hospital that are either outside of the hospital library was managing, or just
No,
yeah.
it's not true.
And this is a cost savings then for the hospital. So we can locate those. If they're in our standardized suite, they now will have access to that. But also there have been times when they're not in our suite. And at that point, we go to administration and ask, if you want this to be for the wholesale health system, this is what it's going to cost. And chances are they deny that. And if the hospital decides to still license it, that's outside of us. I want to really point out key decision makers. This is so important to identify one or two key decision makers within the health system who are actually champions and understand libraries, understand the value of the resources, and understand the costs involved to have a well-unified clinical enterprise with information resources. In our case, I credit my predecessor who established a relationship with the vice president for sponsored programs, research support, and graduate medical education across the entire clinical enterprise. And this person truly recognizes the cost of the resource. We communicate with her throughout the year on pricing increases, bringing in new health systems, and what those costs are going to be. So it's not a surprise at the end of the year when we invoice them. And then in the last few minutes, I have 2 minutes, I just want to talk about some challenges. We mentioned that it is most successful when there's a hospital librarian on site, but in those cases where there's not, that's oftentimes the case as well, is the challenge for us then to take on that role of identifying clinical staff, getting the word out, figuring out what the resources are, all those things that really the value of the hospital librarian brings to the table. When that doesn't exist, that actually is quite challenging. I will also say, within this past year, I mentioned that the health system has maintained the hospital librarians during their mergers and acquisitions. Unfortunately, though, this past year, our health system laid off 1% of their non-clinical staff, and several of those librarians got laid off at that time. Another important challenge is balancing expectations. Whenever anybody in the hospital hears of a merger or acquisition, we have phone calls right away to ask, hey, now can I have access to X or access to Y? So just managing those expectations, that's going to take time for the resources to be actually up and ready, and that's a challenge. I already mentioned the costs beyond licensing. Really define, if you're in the academic library, define what your role is going to be and those associated costs up front. And also finally, the communicating outside the health system. As I had said, in our case, we are PIT employees in the academic library, and they are UPMC employees in the health system. And those communication channels, we don't have those. So if we're trying to reach into the health system to talk to somebody, they don't necessarily recognize who we are. So to get a dole appointment, I will say the years that we've been doing this, just this past year, we were able to get a dole appointment for a program manager. So when we don't have those connections with a librarian on site, we have this dole appointment now that can make those communications. And with that, looking forward to questions or discussion.